Welcome, everybody, and thank you for being here today with myself and Rebecca Burgeron. She is an amazing speaker of perinatal care, and so I'm really excited to have her at the Perinatal Acupuncture Conference in May in San Diego. And we're going to have her do a special talk talking about breech babies and using the diaphragm to treat breech. So I will let you take it away, Rebecca.
Oh, cool. Thanks. So yeah, I thought this would be short, but I kept adding slices, and so I think we should be okay in the time frame we planned, but um, I might talk a lot. So a bit about me for people who don't know me. Um, I'm an acupuncturist. I love being an acupuncturist. I love needles. I love how Chinese medicines gives you a new lens to see things in a more complex and nuanced ways, especially in childbirth. But I'm a wannabe midwife. I consider myself a doula first, and a doula with needles, and an acupuncturist later. But I've always worked near the childbirth space. My clinic is 95% uh, perinatal care. So yes, I do pregnancy, also some fertility patients, and some postpartum patients, but mostly it's third trimester and birth. So childbirth prep and then the actual childbirth. This was me during my birth. I'm acupuncturist because I have an evil bone water here in my birth space. So this was my social proof. And then I'm also a teacher. I love to teach, but I love to teach because I love to talk about my passion, which is childbirth. I enjoy to teach too, but I mostly just enjoy to talk about pregnancy and childbirth. So this is kind of not that important. So why should we treat breech babies? Except then the obvious people are coming to us for this. I mean, why is it more super important to treat breech babies? I'll do my editorial after. I'll start just by giving you a few statistics. About like a quarter of babies are breech at 28 weeks. 7% of babies are still breech at 32 weeks. Sometimes we can get them in clinic at this point. I don't know how often you get to see them that soon, but I prefer it that way. And then at birth, at the actual birth, while they are in labor, 4 to 5 babies are still breech, and then there's a lesser percentage that are transverse or oblique. So transverse is, I call them the baby cats because they're like snuggled between two tight space like this. So this is still a small percentage of birth in total, but it represents like around 11% of all of total C-section in the United States. So what this means is that most of them, or maybe almost all of them, depending where you are in the world, and if the breech vaginal birth is an option or not. So I added or 81% will choose or be forced to choose because most of them won't have a choice, a planned C-section for their breech babies. And out of these people that did get an elective C-section for their birth, around 21% will attempt a VBAC for their next pregnancies. So that means, yes, this is a lot of C-section for that first breech baby, but they're kind of condemning the other baby to also be born by C-section. So you're not just treating that baby and that mom, you are also treating all of their siblings that are coming after and will suffer the consequences or added risk factors due to the first elective C-section. And I added a few stats on that. Sorry, I just need to I click on something and then I'm happy to see your face, but they're all over my screen. And I don't see what I wrote. Okay, this works. So this was done in Finland, but it's still I think, relevant here. They did a study, so the first birth was an elective C-section for breech baby, and then they looked at the risk factors for all the subsequent deliveries, including other C-sections or urgent C-sections or plan VBAC. So, and they saw an increase in morbidity for maternal and infant. So even if you have a patient that choose to go the C-section route, if they choose to, it's perfectly fine. That's their birth and they can choose that. But let's say they were forced to choose that option because their baby were breached. And then for the next pregnancy, even if it is an elective C-section, they're still at greater risk. So that first C-section follows them along and follows them for all their next deliveries. So maybe we're going the safer route with an elective C-section for this baby, but we're just pushing the risk forwards for the next one. So this should be part of a greater conversation. But if the baby is in a cephalic position and like happens to turn around, then everything will be simpler for that family and that labor, and they will have more option and more support to breathe vaginally. So I wanted to give you like the greater picture, or you're not just treating that baby and that childbirth and impending childbirth, you're also treating the siblings that are coming after. And I wanted to add this about ECVs. ECVs are external cephalic versions. So someone, not you, hopefully that's not within our scope, will turn the baby around to place the breech baby and turn it in a cephalic position. And they found out that there is a probable increased risk for babies that were turned by ECVs, a greater C-section risk than the babies who turn spontaneously. So what does this mean? Let's say the baby was breached because of muscle imbalances. Even if you force the baby to turn, you did not correct any of the underlying muscle imbalances that will still affect the birth that is coming. So treating a breech baby with acupuncture is safer than the CVs because we don't have all the added possible side effect of ACVs, and we don't increase the rate of emergency C-section after our treatment. So let's turn those baby spontaneously, hopefully, and hopefully this is what the baby wants to. So this is not a full training on breech birth. It's just I wanted to talk about the diaphragm because I think we like kind of forget how important it is. Why I had two pictures there. Why did the picture go? Oh, sorry. So you'll imagine it with your imagination. This one worked. So this is all the layers of the baby coming from the skin to the innermost layer. I just wanted to show you a bit how many things are happening around the baby and how the space, the cradle around the baby, we need to think about it in 3D. So the baby is surrounded by the diaphragm and the ribs. And then, of course, the pelvic floor plays a big role, but everything around the baby in the space can restrict movement and maybe keep them in a breech position against their will. And we're going to talk about the superior, the top of the cradle, so the diaphragm. And I love this image. I love to compare a diaphragm to jellyfish because the movement is the same. The contraction that builds up the pressure and pulls the air inward, and then the release of the diaphragm. Sorry, I tried to incorporate videos and it's the first time, so bear with me. It's maybe not as smooth as I wanted. So how often are breech babies stuck because of a diaphragm? At my clinic, I would say 1 out of 6, where the main culprit, most often it's multi-layered problems, but the main fire we need to extinguish. About 1 in 6, in my experience, is the diaphragm, and then you have baby especially stuck in the right rib cage. Like the diaphragm is like pulling the baby, and the baby is stuck in the right rib cage. And by releasing this dome, we just help the baby move and create more space, and then they turn around. So this is why treating breech using the diaphragm could be pertinent, could be useful. So the diaphragm, another video, it lines the thoracic cavity from T7 to T12. Some spinal fibers are attached to the lumbar, so we kind of see them around. They're asymmetrical, so they do not reach the same length. One is toward L1 and L3, and one toward L1 and L2. And it works in a vacuum with the pelvic diaphragm, so the pelvic floor, building pressure and releasing pressure synchronously. And the diaphragm during pregnancy, is there changes to the diaphragm during pregnancy? Since everything else changed. I need to take the picture. Okay, good. So I'm just going to read this code. The capacity of the respiratory muscles to develop pressure therefore seems preserved during pregnancy, even though the geometry of the chest wall is significantly affected during pregnancy. Abdominal muscles lengthen and change their muscle insertions while preserving force development. The diaphragm is shifted cranially at the end of pregnancy. Concomitant with the progressive change of chest wall shape during pregnancy, the diaphragm increased its contribution to both spontaneous and maximal breathing, maintaining its thickness, despite its lengthening due to the growing uterus. So even if the diaphragm is being lengthened, because mostly it is pushed by the uterus, it still keep the same thickness from the first trimester to the third trimester. So these results suggest that during pregnancy, the diaphragm is conditioned to optimize its active role provided during parturition. So even if many changes are happening all over the body and it's kind of traumatic and hard and quick, the diaphragm mostly does its job. So this is the diaphragm in relation to the pelvic floor. So you can still visualize your jellyfish here. So on the inhale, the air is coming in, the diaphragm contracts and pulls down, and then it releases, and on the other side, the pelvic floor contracts. So the pelvic floor is gonna move, it's gonna release and contracts to accommodate the pressure change that the diaphragm forced. So they should be moving this way. Sometimes people have an inverted reflex, so they're going to contract the diaphragm and the pelvic floor at the same time, and they're going to release their diaphragm at the exhale while releasing their pelvic floor. So this is something that PTs, perinatal PTs, will maybe pick on, and it's not optimal if they have an inverted reflex. So this is a breathing exercise you can help them, like just to be aware of their pelvic floor movements during the inhale and the exhale. Just bring their awareness to that. So you can make them place their hands on their diaphragm or on their coastal space and just start by feeling that muscle. If they can't feel it, you can tell them go inhale and inhale deeper and wider than you usually do, and hold it until you start to feel a tremor in the muscle that is being strained by the inhale. So they could feel like their diaphragm that way. And once that is done, and they can feel it contracting and releasing, they can put their awareness toward the pelvic floor. If that's too hard and they cannot feel it release or contract, they can just put a hand on their perineum and have something physical that can feel the release and the contraction. And if they are not able to feel it the first time they try it, it's okay. They can this is why pregnancy is fun because it's long. We have time to prepare stuff. We have time to practice stuff. So they can practice it until they really feel at the inhale, the perineum, the pelvic floor relaxing, and then at the exhale, and they can push the exhale further and compress their abdominal just to feel it contracting a bit more until they can see it and feel it, and it becomes natural and normal for them. All right, so this is not I hope it's not too loud for you. I don't need the sound. I just wanted to show you here how much during this woman breathing, our pelvic floor is moving and our hips and all this lower area is moving almost even more than the diaphragm. Okay, I'm sorry if the sound was loud. And that baby seemed to have quite a bit of fun in there too. So both are moving, and at the inhale and the exhale, both are going to create pressure changes and big movement and shift in the available space in the uterus. So a bit more on the diaphragm and the pelvic floor. So if are there any people using balance method or TAN in their clinic or tongue points? I'm not going to give a whole course on that, but analog structures will treat analog structures. So the more similar the structures are to one another or in relation to one another, the more you can use one to treat the other. So in this cross section of the diaphragm and the pelvic floor, it is kind of really obvious that both are the same shape-ish. So the dome upward and the dome downward, both are walls that separate the jaws. So you have the wall and then the outer exit, and then this wall and the upper exit toward the mouth, toward the vagina, toward the rectum. So you can definitely treat one to treat the other, or treat one just because you want to treat this one, and as an added bonus, you also have an effect on the other. So having that baby for breech pattern, I often see, like I said, the baby being stuck in the right rib because there's too much tightness in the diaphragm. But sometimes there's just down and stuck in the pelvic. So they are like stuck here and they cannot go up and they cannot initiate their rotation. So even if you're not sure where that baby is stuck, because you haven't yet developed the skill to palpate and find and localize that baby, it's okay. You can treat the diaphragm. If the baby is stuck in the diaphragm, it will help. And you can treat the diaphragm. And if you got it wrong and it was stuck in the pelvic floor, by treating the diaphragm, you're also going to treat the pelvic floor. And when in doubt, treat both. So they both treat themselves locally and they both treat the other distally. So you get the whole package of the cradle and you get an even better treatment. And then on this picture of the diaphragm, I wanted like just to show you how these, like the top of the ribs, kind of look like iliac crest. So the top of the iliac crest compared to the downward movement of the rib, and then the xiphoid here, how it looks like a pubic bone up front. So the more similar the structures are, the better they are at treating one and treating the other. So for needling the diaphragm, the easiest way and probably the safest way is to I use 7mm needles. So even if you stick them in perpendicularly on the thinnest person on earth, you're not gonna reach along. You're just not. So these are the smallest one. So these are by AcuRelaxo, but Tiwa has some too. They're called detox needles.
Did you say those are
So they're
half
like,
inch needles?
hmm?
Half inch needles? Is that right?
I think, or even maybe, yeah, half inch or less. And close to the camera can be
You can't
to
really
show
see.
them.
Yeah, it's hard
Yeah.
to
There are very thin needles. They're very small. But I included the
see.
length here. And you just palpate all of the intercostal border, and every time you feel a tension or something is stuck, you just stick a needle in it. It's not hard, it's not long, and it works. I know I'm not needling directly the diaphragm, but by needling the space, I have an effect on the diaphragm, and I'm super safe. So you can do this like while they're sitting. At the end of the treatment, I usually teach moxa at bladder 67 at the end of the treatment. So they're sitting. I want them to see what I'm doing because I want them to do it at home. And while they're looking at me, they're sitting, and it's super easy to hit all all of the points here that are stuck. And those I free end. They're like those are my favorite needles. The fact that they are pink is unrelated. My whole clinic is pink. But they're very, very nice and quite painless too. So I do this. This works like 90% of the time, and you can combine it with diaphragmatic breathing to get an even deeper and more a better release of the muscle.
We had a question, Rebecca.
Yeah.
Somebody asked, can this be done in early pregnancy to prevent issues
Oh
later?
yeah. Of course, you well, there's two things. You can needle the diaphragm like this on anyone at any stages of the pregnancy to help them breathe better or be less breathy. Well, some people are really like olive breath, so you or a big reflux, gastric reflux. You could also think of the diaphragm for other reasons, but in specifically in breech cases, you can start treating preventively at 28 weeks. I don't do it on everyone. I don't recommend it to everyone. But let's say someone had an history of a breech baby, they are more at risk to have another breech baby. So if your first baby was breech, your risk to have a breech baby at term is 10%. And if you had two older baby that are breech, the chances of your third one being breech is 16%. So let's say she had a C-section for that, she had a C-section for that, and she's like, oh, this last baby, my last one, my last chance to have a vaginal birth cannot be breech. And I would say to her, well, there is something in your pelvic or your pelvis or your bones or your something in you is creates an environment where baby love to be breech or cannot turn. So let's treat preventively at 28 weeks. And then you release everything you feel and see. You can start earlier. And I didn't include it in the stats, but there was a Spanish researcher that asked themselves the question, can doing mock if we do moxa at bladder 67, will we increase the risk of premature birth? And they started at 30 weeks. And the answer was no. So their conclusion was you can do moxa at bladder 67 super early, and you will not increase premature birth risk. So if you think that it's pertinent for your patient, you can start early. You don't have to wait till the baby is at term or near term. So you could start at 28 weeks too if you have reason to think this next baby is going to be breech, or if it's super important for that patient, you can start earlier. There's no problem with that. So I hope that answered your question. If you have a follow-up question, feel free to ask. And then you can needle the diaphragm, the actual diaphragm. This is from Perinatal Electro this is a mouthful, anatomical guide for the electromyographer. So these are all motor points for all muscles, and you can needle the diaphragm directly. Maybe not try this in the clinic for the first time without supervision. I would try this under a clinical supervision before you go on your own. I just wanted to tell you this can be done. And in that angle, you need to if you go further than 40 millimeters, so 4 centimeters, then you can puncture the lungs. But if you're under 4, you won't puncture the lung. So 4 centimeters. Ah, it's like big like that. I don't know. I think treat sun is 10 centimeters. So that would be a quarter of a treat sun. That was some stupid math I did right there.
There was a couple more questions
Yes,
coming
sure.
in. And maybe you can just email this to me later to get the title of the book, because it was hard to see on the screen.
Yeah, it's
I'm gonna
it's
type it in.
under there. You're gonna get the slides during. I'm gonna
Okay,
send you the
perfect.
slides.
We'll send that
Yeah,
with the replay then. And then somebody else asked,
perfect.
do you ever do any body work prior to the needles on the abdomen, on the diaphragm before doing like for releasing the diaphragm?
I sometimes do. I don't do it all the time, but you could totally like get some nice oil there and just glide along and follow our breath, follow our natural breath to release the diaphragm. It releases well with body work and cupping too. If they have heavy rib pain, and if I'm like, okay, I'm treating the diaphragm, and they're out of breath all the time and they have like rib cage pain, I'm sometimes I just pop a cup and I slide it along and I do the whole 360. I don't just do it on the front. I'll go on the back too, and it feels amazing. So I don't always do body work to release it, but sometimes, depending on how much you need an immediate release. But this works immediately. It works really quickly for such a simple needling technique.
Thank you.
Was there any other question?
No, that was it for now.
Okay, cool. So, like I said, do not attempt this on your own unless you're used to puncture, to do deep puncture. But I just wanted to tell you it's possible to do so. But this works super well and is way safer. So you can just use the small needles and puncture right under the rib cage and follow along and just needle the tensions you feel under your hands. So the diaphragm and the daimai. This is not a direct quote because I translated Ranidin book in French, part of them, and I forgot my book at my clinic. So this is the translation of my translation. So these are not direct words. I just wanted to announce that to you, but you'll get the sense and the meaning is still there. So between the 30th and 36th week, the baby received the jing of the under joints and begin to move his shoulders before the baby turns around. That's a baby that do not intend to be breech and want to turn encephalic. So the baby will move their shoulder, flex their head, and by moving their shoulders, will release the Dao Bao. So at 21 spleen. So the first wrapping channel here and in line with 20 spleen 21 in order to release the daimai, so the other wrapping channel. So babies are doing balance method. They're releasing one area of the body in order to release the other, and they release the daimai to open the daimai to open the hip to facilitate birth.
There was a
So
couple of
this
questions
is,
that just came in
yeah,
too. So just to clarify, you're just needling in between the intercostal spaces and then following along the rib cage. Is that correct?
for the kneeling. I'm gonna go back then. I'm gonna try to show you on. I'm just under so I start on the middle on Renmai, and then I go downward, and each time I feel a tension. So I would needle here, I would needle here, and I want to exaggerate. I'm under the rib cage now, so I'm in that space, right under the rib cage, and I'm just needling tension in that line. I'm
Perfect.
not in, I'm not between two ribs. I'm under the last one here.
And then there was another question, is it as effective to do lateral insertion rather than perpendicular?
You could do lateral and have a bigger needle. It's just that the needle I use is so small that I can do perpendicular. And if I do oblique or perpendicular, if I lateral insertion, I will hit like only the skin. I will get no other. I don't think it'll be as therapeutic, but if you have a longer needle and you want to angle it, that would work super fine too. You see how big that needle is and how it's angled, and it's still safe if you do not go higher than 4 centimeters. And for mine, I'm gonna try. Imagine my my finger is a needle. So I'll just palpate the space, and when I found a spot, I hold it and I needle like upward. But when I release the skin, the needle is seems straight. But while I was needling it with a small, and then I angled it toward the diaphragm. But as soon as I release the skin, it looks like a perpendicular insertion. But you could still needle it perpendicularly. Those needles are so small, you will not puncture alone. So I hope that was clearer.
Okay, that's good. And then let's see, there was another one. Do you needle front and back for releasing diaphragm?
With this, I do only on the front.
Only on the front. And then what was
Yeah.
the needle brand that you use? Your favorite needles?
So I can. So the Acurelaxo, but I think they're a Quebec brand, so you might not be
Oh,
able to get those. But Tiwa Detox too have the same. Why cannot Control Enter? Okay, I don't know why I'm not able to post in the chat. Tiwa Detox.
what?
Sorry. Yeah, what? Yeah.
K
Control Enter.
K-E-W
Well, I don't know why I cannot post in the chat. I tried. Sorry.
Kewa, is that what it is?
Hmm?
Kewa?
Yeah.
Okay, there you go. I posted or
And they're used for auriculotherapy. I
Kiwa.
think they're
Oh,
branded for your ear, but I use them everywhere. They're great to needle Fouquet too. So the tongue point on the thumb, that is amazing to release the daimai. Yeah. So I use them everywhere. But for this specific technique, I only go on the front to release the diaphragm. If I do cupping and they have like pain all around for the rib, I will do the whole circle. But let's say it's a breech baby, they have no pain in the diaphragm, they have no pain in their ribs, but the baby is still stuck upward. I will only needle on the front. That works. And I might do body work depending on how I feel this day. Yeah, if that's not enough and I need something more too. And keep asking questions. That's super nice. Thank you. So this was just an example. This is Taoist philosophy, but I wanted to branch with actual anatomy. This is the spiral continuity of facial plane. So let's say you have a baby and you want to baby wear it. You are a big faggot of weed you want to move along and you need your hands free. How will you attach something to your torso without it falling apart? If there are people that are used to baby wear, you will cross the center line. You will do an X under the baby's butt to hold it in place. And this is the thing the body is doing with facial plane to hold the baby and accommodate the growing uterus. So the uterus is growing and projecting forward, but the facial plane starting from the coast, the rib here to the top of the iliac crest will do an X on the side and on the side. So the weight you have in the middle is held and is more secure and not just falling upward. So your belly is not projecting too much. And then that facial continuity goes downward to the lateral side of the knee. So here you have your Dao Bao, your first wrapping channel at spleen 21, and you have your daimai, that would be the correspondence at GB 27 at this point. So yeah, while in balance method, we treat one analog structure in order to treat the other. Here, we are actually also treating one to release tension in the other. Because if your X, your band of, I'm gonna use an actual baby wearing here. So let's say I have here, it's stuck and it's stuck here. I could give me more loose here to release tension here, or I could either release tension here to give me more space here. So you could use, and I use spleen 21 to both release the diaphragm and both release the daimai. So with one point, I release locally here, and I release the diaphragm right underneath, and I also give me more space in all of the facial spiral continuity. So I open up the hip too. I don't moxa on spleen 21 all the time. I use them if my first tools don't work. And I'm like, that baby is still stuck. The hips are still super tight. What is happening? So I use moxa on spleen 21. You could needle it. I just prefer to moxa it, just personal preference. And it works well. And I love moxa too. And it feels nice. So I do it here bilaterally to release the crossing X and then give more space in the cradle to help the baby to have more room to turn around and loosen up the hips too. Another fun bridge between our practices and anatomy. Jean-Marc Quespi, he's a French author. He has a book on extraordinary vessels. And he said that in Japanese palpation, I don't do Japanese palpation. That's what I'm citing this author. It's just a fun link I wanted to share. In order to palpate the daimai, to put a diagnosis on the daimai, they will palpate this area here on the lateral border of the knee. So by palpating this end of the spiral continuity, well, it continues, but by palpating this knot here, they are able to tell the whole, how is the daimai going? Is it tight? Is it too loose? Is it full of water? Is it working? Is it healthy? Or is it, or it's not? So I thought that was a fun link too between anatomy and like I said, I practices, but I don't practice Japanese palpation. So I'm just citing the author that mentioned it. And then I made the bridge with this special plane.
So
Uh,
interesting.
so, hmm?
So interesting. So cool.
Yeah.
Uh,
Well,
do you want to share
uh,
the name of the author and that book? Or maybe you could email that to me too, and I'll send that out with
yeah, because I cannot.
the book. No
It,
problem.
it's it's an old book. I like don't jump on it. It's okay if you've never heard of extraordinary vessels. It's a good introduction, but you won't it won't revolutionize your world. It's not like wow, mind blowing. Renedin's book is mind blowing. That you can buy. You can buy Jean-Marc Quespi too. Just I wanted to cite someone, but it's not like the best book out there, but it's not bad either. It's a good introduction.
Thanks.
So other ways you can open up the rib cage and release the diaphragm is by doing suspensions. So just by hanging yourselves. This was in my clinic. I just used two rebozo back to back. You can use like a sheet of a big sheet, like a single bed cotton sheet. That would work. You don't see it, but on the other side of the door is a knot. So you need a knot. You pass the knot on the other side, and then you close the door on it to make it super secure. And so it's an easy way to hang yourself without buying something fancy. So this works too. I don't want them to squat. I don't want them to exercise their glute. I just want their body weight to extend the lungs and extend the rib cage. And like I want, if just like I want to give them a bigger torso, a longer torso. So I'm stretching them upward. And this was me also. This works too. Or they, if it's summertime and they have older children, I tell them, if you go to the park, just grab the monkey bars. Do not lift yourself up, just hang. Just let your body weight stretch the whole area. So they can do this too, like 30 seconds to like 2 minutes. As long as it feels like good to them. But in clinic, I make them do it for a minute just so they can feel it. And while you're suspended this way, you have more support to the low back too, so it's more comfortable than just hanging by your hand. And you can like kind of play around and release the muscle more just by moving with them. So that's nice too. Another way you can do kind of the same stretch in clinic. So in these illustrations, they are on hands and knees on the ground. Please install them on your table. We have comfortable tables. So imagine this is a treatment tables. And instead of you lowering down, you would be standing upright because I assume your treatment table isn't on the floor. So we'll just be upright. Here I also use rebozo, which is a Mexican and woven scarves that the midwives use there, but you could use anything that doesn't glide. So don't take something silky or too soft. You need something with a bit of a grip in it. And you just pass it underneath their hands, like this here. And you don't pull on it. You just instruct your patient, go sit on um cheville. I have here. This part of the anatomy.
Ankles.
Your ankles. Yeah, thank you. Just go sit slowly. Put your butt on your ankles and stop while you feel that the stretch is good and feel nice. They usually don't go all the way down. You're not pulling, you're just holding them. You are secure on your feet and you hold their weight while they are slowly sitting on their ankles. And they control the stretch, so they stop when it feels nice. When they found that particular spot, I tell them breathe deeply 3 times and then, okay, go back up on all fours and then go down. And usually they go even farther. And then again, three big, full, nice breath. And then we go up. And then a final time, they go down and you just hold. You just hold their weight. They control the stretch. And this is nice for anyone pregnant that have back pain or higher, like scapula pain or like higher back pain. But I I'm teaching you this in the bigger picture of releasing the diaphragm and opening up the rib cage, but you could totally use it in other contexts too. And it's easy to teach. I do it one time and then I tell them, do you have someone at home that could do this for you? And they say yes. And then I tell them, just do the same thing whenever you want, once a day or a few times a week to open up more space in your torso and help you breathe more easily too. So I hope that was clear enough without me actually showing it to you. You can practice it up a few times. It feels nice for everyone, so you could try it at home with somebody today before you try it with a patient. Like I said, don't pull on the spine, just hold the weight while they go down. This is another super fun exercise. It was especially invented for breech baby. I'm not gonna teach it to you. I just wanted to open up some doors that are other things you can do in the clinic to give more space in that whole area and open up the cradle for the ribs and the iliac crest. So you're both opening the pelvic floor and the diaphragm at the same time. So yeah, just just know that there are many things out there you could do to release the diaphragm. If you have other tips, if you love gua sha or if you love like specific techniques, I don't care what you use. I just want you to not forget the diaphragm exists in your breech baby treatment. And this one I'll be teaching live with the demos during my breech baby work day. This was me yesterday. I just taught this class. This is super fresh. It's and this one works so well that it's contrary. It don't do it if you're not sure the baby's breech because it opens up so many space that a cephalic baby could theoretically turn and be breech again. So only do it if you're very sure that this baby in front of you is in breech position. If you're not sure, just don't do it for that treatment. Good. So any questions? And I'm okay in time too. I'm glad I rolled that without looking at my watch. But
Good
I
job.
have, I have time to answer some questions.
Yes.
I hope my English wasn't rusty. I'm like a bit sick, and my brain is like full of brain fog. And like, what are the words? So I hope it wasn't too bad for today.
I think you did an excellent job. It was very interesting. You seemed to answer all the questions as
Cool.
we went along. So it's really wonderful to see all these great people here. They're saying so helpful. Oh, we have another question. Other than deep breathing, is there any, oh wait, let's see. Other than deep breathing, is there any particular breathing techniques that you would use to release
I
the
start with this one because most people are just unaware that the diaphragm exists and their pelvic floor exists. Both muscle are out of mind, out of touch, out of mind. So for first step, I just want to them to feel like, oh, I have this muscle here, and this muscle makes me breathe. And oh, I have muscles in my pelvic floor area somehow. It's not shameful. I can touch them. So I just want them to feel the connection between the two. But yes, there could be like bigger breath work. You could also teach people, but I just start with the basic in the clinic. I just want them to feel and know that the both of these structures exist and work together. But if you have like let's say you come from a yoga background and you have other beautiful techniques to release the diaphragm and do diaphragmatic breathing, of course, teach them and use them.
Everyone's saying excellent,
Yeah,
excellent.
I opened the chat. Thank you, everyone.
Um, let's
Yeah.
see. Yeah, so
Yay.
Rebecca's one of our speakers at the Perinatal Acupuncture Conference,
Yay.
and she's having a master class on the day
Yeah,
after the conference. So tell us a little bit about that class.
well, I'm talking about breech baby, but 360. So sometimes babies are stuck under the right rib, sometimes they're too engaged in the pelvis, and sometimes the mom isn't ready to birth that baby and she's stuck in her shed emotionally, and that's what's holding the baby together. And sometimes the baby just needs a little or more energy to move. Sometimes it's both or all of these things combined together. So I'm kind of teaching all the angles and all the things that could impede a baby's rotation and how to resolve them or treat them, or just acknowledge them to our patient and validate our feelings, sometimes just by validating our feelings. that childbirth is scary and she's allowed to have a planned C-section for that breech baby. Sometimes it's just the emotional release she needs. So I'm teaching those techniques as well. And so like a whole day on breech baby. So you are super efficient and super good at it and able to treat all the the small specificity because it's not always there are many breech babies but they do not present the same way and you shouldn't have just one treatment for all of these women. If you have individualized treatment and you are able to feel and palpate and know what they need the most, you'll be able to have better effect and turn more babies and avoid more C-section too. And so that's my breech baby. I'm not able to post link, so I'll include it in the email. I'm giving you all that are listening now $100 off the regular price. And if you buy the, why is it going backward? If you attend the whole Perinatal Acupuncture Conference for more fun, you get a 200 discount of the breech baby class.
Yes, we're very excited for the conference. There's so many amazing
Yay.
speakers, and Rebecca's talking twice during the weekend. So it's like, she's
once
coming.
on once on C-section prep, how to, let's say that baby is breech and that mom is at peace with an elective C-section, or she chooses to go that route, or she feels safer and it's perfectly fine. Then what treatment can you offer to her just before the operation, during the operation, in the operating room, and right after, and how you can help her in the postpartum journey. And then another talk is on induction, pre-induction treatment. So treating right before the induction starts.
Such great information. So helpful for our female population. So much that we can do as acupuncturists to help during the perinatal time. And it's really cool to have all of you who are also perinatal acupuncturists who are wanting to support our pregnant communities and mamas and families and all that good stuff. So I hope to see
Yeah,
everybody there.
I
And
know. Someone said, "Don't forget a pregnant trans dad." Absolutely. Like I use inclusive languages in my class. I said maybe I send women more this time or moms, but I'm in my heart always included everyone with a uterus. They all need help, and everyone needs support and help and love and respect and care. So yeah, don't forget that. Or
uh,
our non-binary uh, parents too. Yeah. Thank you
yeah,
for mentioning it.
that is great. Yeah, we're looking to create community and build bridges and help support more and more individuals. Let's see. Somebody asked, is a conference in San Diego? So the conference has CEUs for California, NCCOM, and ABORM. So you can get your ABORM CEUs as well. This is being done through Net of Knowledge. So I know we have a lot of people in Canada that are coming in Mexico as well. So it's going to be an international conference. And we do have a couple discounts for being in this class. Type in the promo code class, all in caps, and you will get a $50 discount. This is for 2 days and it includes all the food. We have two lunches as well as a networking dinner Saturday night. Again, just really wanting to build the community and make it easier for people coming in from out of town. We did get a hotel block at a hotel called the Dana, and all this information is on the link for the registration that I put in there. I'll do that again. But you can get it's like half off. Rooms in San Diego were over $400 a night in this area. So we got it down to like 190. So that really helps. So if you are needing a room, mention the Perinatal Acupuncture Conference when you contact the Dana and you will get discounted pricing. It is within walking distance. It's like a half a mile and it's gorgeous. It's right on the bay, the water, and oh, dreaming of my next trip to San Diego for sure. Awesome. Let's see. Any other questions, comments?
If you have any further questions, I'm still here.
Yeah, we still have a good amount of people.
Uh, for people that are still there, you can treat breech babies. I'm doing like another editorials up until the end. Don't abandon your patient at like 37 weeks because it's too late, quote unquote. You can treat up until the end. So don't if they want to try, you can totally help them, even if they're 38 weeks or 39.
Yeah, I've helped people up to like 41 and a half weeks with turning the baby as the baby just turned. But if the baby was breech the whole time, do you feel like that could still help it even towards the end?
Well, sometimes mm, as the weeks go by, you have less and less chance of turning that baby. But sometimes the thing that is holding that baby is not biomechanical. Let's say it's only an emotional blockage. It's only a chi stagnation, emotional chi stagnation that is holding that baby. Maybe that baby has space up until the birth. Some baby turn in between two contractions. How do the no clue how they achieve that, but they do sometimes. So if it's a biomechanical issue and if she's stuck everywhere in her belly, she has a bigger baby, less amniotic fluids, at 41 weeks, it's going to be hard. And the baby's fully engaged in breech downward. Like so it's gonna be hard. But sometimes that baby is still IHOP in the space at -4, -5. There's still much space in the pelvis, and everything is loose. There's empty amniotic fluids, the not no muscular restriction, and that baby or that mom just needs to let go and trust and surrender to your kidney energy and trust that the universe has something in for them and they're going to be okay on the other side. They need to accept that they're going to die as a maiden and be born again as a mom or a dad or a non-binary parent. And that baby too needs to accept it's going to die as a fetus in order to be born as a fully breathing baby. So if the blockage that is keeping the baby breech is something um, in the connection of kidney and heart or something in the shen, it totally you can still help them at 41 weeks or 42. Some, but of course, the more you wait, the harder it's gonna be. But don't abandon them.
Yeah, there was one more question. Somebody said they had a patient, they succeeded to turn the breech baby, but then right before labor, the baby turned breech again. Like I guess it worked out with acupuncture. Do you
Yeah.
have any ideas what that reason could be or why that was happening?
Uh, there are many things that could have happened. It often happens during ECVs. So they turn the baby by external maneuvers. They force it in a position, but nothing has been corrected in the muscle imbalances. So the baby turned back around right the day after or something like that. So if we do a parallel between those two, let's say your treatment released the psoas, and the psoas was like blocking the baby rotation or whatever the iliac muscle, some a muscle with whatever it is blocked the baby. Your treatment successfully released it, so the baby was able to turn. But something in the way she sleeps, she sits, or she held herself in the space will recontract the muscle again. So the baby is now stuck in a non-ideal position and it's now more comfortable to turn back again, breech in the original position. So so this is just an hypothesis that your treatment worked. The thing blocking the baby was moved out of the way or was released, but the mom did something, maybe she fell or she lifted something in a torsion in a bad movement that made the muscle contract again, and the baby was like, oh no, this was comfortable when this muscle was released, but now that it's tight again, F it, I'm turning back breech. Because the chances of the thing you're telling happening is 0.54%. It's less than a percent. As soon as you're past 32 weeks and your baby is in a cephalic position, the chances that they turn back breech is 0.54%. So it's not impossible. Maybe the baby had a change of mind and they were like, after your treatment, full of confidence, and they're like, yeah, she did bladder 43 and the kidney shoe points, and I'm okay, I'm trusting, I'm going in the darkness, and I let go, and I'm not panic, I don't have any anxiety, I can be born I can accept the process, yes, yes. And then maybe after a few hours or a few days, the baby's like, no. No, I don't have that confidence. I don't know where that came from. Maybe the acupuncture treatment, but now it's gone. And I cannot do this. I want to be close to my mother earth again, and I'm turning back. So people
That's
are not static. They're organically moving toward their lives and their values and their fears. So maybe her mom had a change of heart, or pregnant parents, and or maybe the baby had a change of heart. Or like I said, it's probably the first scenario. You release the muscle and then it got tight again for whatever reason. And the baby was like, I'm not comfortable anymore. And they turned back breech.
great.
Do you recommend?
I had this patient who booked an initial with me a few weeks ago, but canceled because it ended up turning. But then 2 weeks later, she reached out to me again as her baby kept turning back and forth into breech. Yeah.
Those babies that are spinning around, most of the time there's too many amniotic fluids. The pool is too big. The pool is too big. If you have polyhydramnios patients that have like Olympic pools of amniotic fluids, turning those babies is easy, but keeping them in that position is hard. They will turn and turn and turn and turn up until the end. So with these patients, I have like a completely different strategies to breach. You need to reduce the amniotic fluids, and then you need to turn that baby. That's the easy part. After that, you need to engage that baby. That baby, once it's turned, head back down, it needs to go down and down, not in the full pelvis. It needs to go even lower, so it's stuck there and it stops moving. It's hard, but it's doable. But the strategy for babies spinning around is not the same as the other kind of breech babies. And someone else said, do you recommend any doula training programs that can support our practice and offering for those in birth and postpartum? For those of us who wants to become doulas as well. Yes, I have some in them. Where are you located? So I love pro doulas. So pro PRO, PRO and doulas, and they have mostly online classes. So I love the way they think. But you could like ask around. Sometimes local trainings are fun too. You could read lots of doula book just to get that slowly.
Yeah, I studied with Dona doulas when I was in San Diego and did the Dona doula training, but then when
Yeah.
I went to certify, they say if you have a medical license and you're serving as a Dona doula, you will not use your medical license. So I ethically, morally could not become a Dona doula because everyone hires us because we're acupuncturists. So I teach some
Yeah.
doula classes. I have some classes on net of knowledge. I teach that in my mentorship. And I think you can, it is very unregulated. So you can be a doula without even
Hmm.
studying, like
But
with
I do recommend the training.
absolutely. It's so much better. Like so many of the things you showed, like with the Robozo, it's like, oh yeah, this is doula stuff that you would learn more hands
Hmm.
of. So it's pretty cool.
So one thing you can do to scout your schools in order to find a school that resonate with you, most of the time they have podcasts. So just listen to their podcast and see if their values align with yours. Because some doula program have values that do not align with mine at all, and I would have been like I would have spent my money for nothing. But I love pro doulas. Their classes are short up to the point, and they have some specialist classes in like VBAC support or gestational diabetes support. But I'm sure there are many other schools that are super nice too.
Yeah.
I just my recommendation would be just get a doula training or read doula books.
There's a million books out there.
Yeah.
All right. Well, thank you so much for being here today, Rebecca. And thank you to all of you friends out there on
Yeah.
Zoom. It was wonderful to see so many faces come together and be here. And we hope to see you in May.
Yay.
Everyone have a great day. Take care.
Yeah, thank you everyone.
Thank you, Rebecca.
My pleasure.
Bye.